Welcome, everybody. I am hosting for Daryl Moon. I hope I do a really good job for him. Lee, it's good to have you. John, it's good to have you. If we're excited to have a wonderful speaker and person today, which is Heidi. And Heidi, did you say your last name? Codel?
Huddle.
She's done some amazing work in her field. And Heidi, I'm going to let you just introduce yourself because nobody's going to be able to introduce you better than you. But I'm gonna caveat that with one thing. This is your time to brag, and nobody will think you're conceited for it. So
Oh no.
brag away.
That won't work well. And I really have two other parties on the call with me as well, and that's Lee Lewis and Allison Johnson. Actually going to get started by turning it over to Lee, because really this was a very much a collaborative effort between Lee, myself, and Allison. And so I'm going to share my screen and turn it over to Lee, and we'll get started as to kind of what the impetus was for getting this started, what we've done. And truly, we are demonstrating that collaboration is not a four-letter word in our industry. Having said that, Lee, let me turn it over to you.
Yeah. So before we do that, does everybody know who Heidi, Allison, and Lee are, or should we do a quick?
We're going to make some introductions, if that's okay. I was just going to turn it over to Lee and let him kind of make that intro, if that's okay.
Perfect. Yes, that's okay, Heidi. I know we didn't get time to talk and strategize time, so thanks for taking charge.
Yeah, it's terrific to be here, and thanks everyone, and for anybody who's listening separately as well. Really something fun that sort of happened, I guess, beginning with a story. I work with an organization called the Health Transformation Alliance, the HTA. And for those not familiar, it's the largest fully employer-owned healthcare strategy cooperative in the United States, where it's mission-driven. It's not a profit-driven venture as a cooperative. But the mission's simple enough around saving lives and saving dollars, finding ways to create compelling savings and significantly better outcomes. And we work with the largest employers in the country. So Accenture, Boeing, GE, Ernst & Young, American Express, Coca-Cola, Caterpillar, companies like this. And we represent about 5 million lives and spend about 30 billion a year on healthcare. And we, in my position here, have had just a wonderful opportunity to see hundreds and hundreds of different solutions and capabilities, and see some of the most sophisticated strategies that any employers have done to try and improve healthcare, to improve the mission. But many of the tools and capabilities that that these large employers are able to use often have minimum life sizes at many thousands of lives. Like our special investigations service saves mountains of money and finds horrific activity in the claims and is able to stop it. But you can't even have a conversation with them unless you have 12,000 people on your health plan. You know, the centers of excellence that we work with is an unbelievable network, coast to coast, 500 cities, a drivable COE, direct contracts, 95% lower readmissions, got to have 5,000 lives to have a conversation, or 4,000, somewhere in there, 4 to 5,000. It's rough. So I started working with Heidi. I've known Heidi for a while now, and she's always been a trailblazer in the industry. And we started having a conversation of, hey, how do we bring some of these capabilities down market? Is there a way that we could crack the system to make it so that a 100 life group or a 50 life group could get access to the same kinds of strategies that JP Morgan and Shell Oil are using? And that was kind of the genesis of the conversation. And then the extension there is, what could that do for us in the world of stop loss if we were able to get some of these really great strategies? And that sort of was the genesis that led to this. And I'll turn over to Heidi and Allison to introduce themselves.
Yeah. So Lee and I, as I mentioned, I call him Mr. Stealth, and I'm his big sister. So So Lee and I have known each other for a long time and have served on various boards and capacities together. And in my various capacities over the 40 years I've been in healthcare, I truly have what I would consider my North Star has been to bring transformation to the healthcare industry and be able to bring all of our knowledge and skill sets, as Lee mentioned, down market, to be able to really improve healthcare and healthcare delivery, healthcare access, quality and cost containment strategies. So that truly is what I've done. And I think that what we're going to present to you today is really going to demonstrate that we have accomplished that. I'm not saying that it's 100%, but we've really accomplished that in the design that we're rolling out to the industry. So Allison, let me turn it over to you.
Hello, everyone. Good afternoon. I've known Heidi for many years, and I put on my bio 35 plus because that just sounded better than the 40 plus, but you said 40 plus, so I can say that too. But a long time in this space. I've been on all different sides of the equation. Started out on the insurance side, worked broker side, ran a TPA for a while, ran an MGU, owned an MGU for a while. So I've done a lot of different things, and the space that I've ended up in is really helping to solve in the self-funded space for brokers and consultants and TPAs. And so Heidi and I and her team have been working together for years, and it's been very exciting because there aren't many people out there like Heidi and like Lee who want to try and solve the problem, but also get creative and not just think, okay, we'll just continue doing it the same way, but maybe put a different name on it. So it's been fun to work on this. We've spent a lot of time on whiteboards, the old-fashioned drawing on whiteboards and coming up with some different solutions. So I really look at it from the stop loss side and helping put together some solutions for stop loss and captives to wrap around the whole solution here. So thanks.
Great. So Lee, why don't you kind of start us off with how we started with all of the architecture and the framework that you designed? Okay, well, let me go ahead and get started. So essentially what we did is, as Lee mentioned, through Health Transformation Alliance, they had built this architecture. And what we did is we took everything that was within that architecture, we deconstructed it and reconstructed it for the mid-market. And so the whole process of this was, how do we leverage the best practices from the Fortune 100 companies to basically improve quality, improve access, and reduce costs? And what I would tell you for the mid-market is to also create what we're referring to as the easy button. And the easy button is really, how do we integrate this such that a lot of the risk areas in the mid-market we're able to mitigate by a reconstruction of it into a different architecture. So let me explain how we did that. So when you take a look at a fully insured product and you deconstruct a fully insured product, everything you see here on the right-hand side are the components that are within a fully insured product. And most everybody on the call understands that. I just kind of, not to be patronizing, but want to make sure that everybody understands what we've done. And so in deconstructing that, we just basically reconstructed it in such a unique way that it will really rival basically what is being done in the fully insured market, but in a self-funded chassis. And so it looks a little bit like a quasi-level funded program. And we're able to aggregate with, as Allison will talk a little bit more as well if you have questions, on a captive chassis so that we can aggregate nationally of all the employers that participate in this. But what we've done is, within this side of the architecture, we've essentially bundled everything back up again, and everything is protected by the administrative agreement, by the third-party administrator, by the stop-loss agreement, and by the RX agreement. But what we've done in a unique way, and maybe when Lee joins us again, I'll be able to share with you a little bit more in detail. And if he doesn't join us, I'll kind of go into detail as to what we've done here. And really what he has created, which I would tell you is ingenious, in that one of the biggest challenge with point solutions right now is that most of them are built on per employee per month, per member per month, et cetera. And once you start adding those PEPMs on top of each other, essentially you've got the sum sometimes is greater than a fully insured product or any other type of architecture that you may look at. So what we've essentially done is all of these, there is not a PEPM in here for any of the point solutions, but what we've been able to do is convert it into an 837 claim file. And by doing so, it runs through the system as a claim. We're able to then monitor it within the data analytics, and it's protected by the stop loss agreement. So let me just pause for a moment and see if you have any questions.
Also, Heidi, my internet came back.
Okay, there you go. Okay, Lee.
So are you saying you just simulate a claim for all these direct pay contracts, everybody's trying to set up?
Yes.
Yeah.
So it's a simulated claim. That makes sense.
Yep.
That's a good way to think about it. It's sort of like the first time somebody used the phone line to send a picture. And it was like, you can't send pictures and documents over the phone line, right? With fax machines.
Right.
But did somebody figure out how to do it? We're doing a much less innovative thing, which is we're finding ways to get administrative, clinical, subclinical, and administrative fees. And we're automating the accounts payable by running them through on a claims chassis or on the claims the claims payment architecture. We're just using it to be accounts payable architecture for other things, as long as it's a plan approved, ERISA approved expense.
And so what's nice is we also mitigate the risk of the employer that's participating, that they're not having to, two things. They're not having to, number one, contract independently with each one of these point solutions. It's done within the administrative agreement. And then two, the plan document protects all of the ERISA qualified plan benefits under that as well. And so we're able to offer it within the stop loss protection as well. Okay. So it really is, it's almost like, okay, this is too simple, but that's what we have been able to do, again, collaborating to bring kind of a best practice streamlined administration. Now, Lee, do you want to kind of go into the advanced primary care? Because I think this is exceptional.
This is, no, you're generous. Thank you. Basically, we all know that the challenge in primary care, right? It's been evaporating for many years. My large employers are suffering from this as much as anybody is, and it is that primary care is getting bought up by systems and bought up by carriers. It is difficult to find, new doctors. New physicians often don't want to go into primary care. And all of this is culminating into a situation where where within like 10 years, basically, you're just going to have emergency rooms, you're going to have urgent care. And then for the people who can afford it, they can have direct primary care. That's what's going to be left if it kind of continues the trajectory or possibly. And so we started saying, look, we've got to get primary care, and we can't just have it be that only our executives have good doctors because they can afford to get direct primary care if the rank and file cannot afford to do it. And so we started looking at, okay, well, how do we activate these primary care physicians? Because they're not taking insurance. Lots of reasons they don't, and it makes sense. They're not doing fee for service. They're not getting into the whole bureaucracy of box clicking and charting and everything else in order to bill through the insurance plans. And so we said, well, what if we could find a way to be able to pay them the way they need to be paid, which is a cash-based membership fee. But the way we must pay them, the operationally, mechanically, we've got to use insurance architecture. Because again, a small employer can sign a direct primary care with a local doctor, and it's no big deal. If you've got 50 employers and they're just in one town, you get one doctor in the town and you're good to go. But once you start getting into multi-city and then multi-state and then multi-time zone, how in the world are you going to operationalize not, even regional, networks of direct primary care, let alone the single owner operators in all these cities and towns, right? So once you hit that level of abstraction and complexity, it's like, well, your people kind of have to do it on their own, or you can get creative about giving them an allowance to pay for primary care, but it's quite challenging. So, and my employers, they've got hundreds of thousands of lives. How in the world are they going to do that? It'd take an enormous quantity of people just to try and manage that, operationally. So what did we do? Well, we started looking at the largest kind of players in the space as a start, who had a number of locations. You see them, many of their logos in the lower right-hand part of the screen. Every one of these companies has, 20 or 30 to 100 or so clinics, and they're usually in 1 to 6 states. And we said any one of them individually is going to be woefully insufficient to cover a big national employer in 2,000 cities. But what if we got all of them together? And that's what we did. So by aggregating all their locations, we're now this slide's a minute or two old. We're now approaching 500 locations nationally, with over a dozen different providers who all have said, okay, we offer this value-based care. And we approached them and asked if, they said, Lee, we're not going to take insurance payments or deal with insurance companies. And we said, well, what about, would you take a payment from a rich uncle? Because here's the deal. Only 13% of our people are going to be able to afford your services or are willing to pay for them. The other 87% can't. We believe that your mission's bigger than 13%. And they agreed. And we said, okay, our commitment is you'll never have to deal with the insurance company, but let us do that. But don't restrict our people from being able to come in and receive care. And the way that you'll be able to identify them, we're going to give you a link. If we can just have the person at the front desk click on one link one time when somebody new comes in or calls in, and they can check and see if we're able to pay you. And that's how you can just kind of check eligibility. But if you can do that, we'll take care of the rest. And we're 12 for 12 of these large vendors saying, yeah, if you can figure out how to do that, we're in. This program just went live with our first employer. It's Prudential. They have 42,000 people. And we've activated now, we're about to, by the end of this month, we should be up to about 60% of the locations will be active for Pru, with their ability now that any Prudential employee can walk into one of these clinics. They'll just show the ID card, which, is a bit vulgar that, for these places that don't take insurance, but they'll look at the insurance card and they'll use that just to validate that they can get paid and show that the person's eligible. And after that, they never have to look at the ID card again. And they just mark in that this person is now visiting and is attributed. And then we have a monthly cash payment will flow into these services, into these locations. And we're super excited about it. No, Prudential did not have to sign a contract. They didn't have to do any data sharing. So all of that liability and hassle is eliminated. And we're going to be activating all these clinics to deliver value-based care, but still paid by the employer in a way that works for everybody.
And so within the system, what we have strived to do within the plan design is obtaining or going after a couple of objectives. As Lee just described, really kind of an integrative strategy, that we've integrated all of the solutions. We've integrated stop loss, as I mentioned. The next aspect of it is we needed to integrate the employee and the plan design into the strategy. And part of what we have seen and that we were solving for with all of this is that we needed to design value-based benefits in order to engage the employees or plan participants to get to the right care at the right time to the right provider. And how we did that in the design is by putting on top of it clinical care navigation, that when an employee, again, we'll put incentives in there and I'll show you how we put the incentives, but if the employee will go through the clinical care navigation for non-urgent, non-emergency type of situations, that we will help them to get to that best care, best provider at the right time. And in doing so, within their benefit design, we will also incent them by doing that. And that's what we're referring as to tier 1 benefits. Then tier 2 and tier 3 are traditional in and out of network plan design. So let me kind of explain how we build it and how we integrated with our partners. And these are partners that are both strategic to, relationships that Lee has, and are strategic to relationships that I have, and strategic to relationships that Allison has. I want to clarify before we get into our partners. One of the things we were striving for in this collaboration was to make it a white labeled product. Okay, white labeled meaning that even though Lee is with Health Transformation Alliance, I'm with NFP Corporate Services, and we're kind of a unique organization, and Allison is much more independent, that we wanted to create firewalls around this with the authority, for example, that we have within our respective organizations to be able to bring this not only to the NFP distribution channel, but to any other broker consultant. And we've put firewalls around that, and we'll kind of demonstrate how we've done that. And Allison is very instrumental in that. And that's part of the RFP process on the stop loss. So this is a product, if you want to call it that. This is a strategy that we have designed that anybody can use in the United States. There are some limitations because of stop loss regulations in certain states like New York. You can't have less than 100 employees because they preclude you from self-funding under 100 employees. So there are some state restrictions around that, but essentially it's 50 plus employees. We can go down below that, but there are some restrictions, as I mentioned, based on states. So what we have done in this integrative strategy, and this is just initially, because I know we as consultants, brokers out there in the community, we like options. Well, to be able to cost optimize this, we had to restrict some of the options, not because of optionality reasons, but because we have to grow to be statistically valid. So when we say we can save 12 to 25% below current market, we can validate that. And hopefully in the future, we can be able to guarantee that going into this solution. So that's part of our objective in streamlining, but also mitigating initially the amount of variability in this, because the more variables you add, anybody who has had any statistical training, then you minimize your statistical validity until you get to some really big numbers. Okay, so the administrator for this, and most people are not aware of this, but SNS Health is one of the largest unknown third-party administrators for medical and RX administration in the US, because they're the back room for a lot of, especially hospital-based type of programs. They have over 800,000 members that they serve. They just actually, numbers-wise, they keep growing, but they're almost close to 1 million members. And so we're going to be utilizing them as the proprietary third-party administrator in this bundle. We are also able to wrap national networks around this program outside of that tier one, which are all the clinical bundles that Lee and those relationships are bringing to us, which we're able to wrap with a Cigna network, an Aetna network, yes, a United Healthcare network, and a multi-plan. We do have the ability to wrap it with Highmark. We're in negotiations with Anthem, but any of you who work with the Blues knows that that's a heavy lift. And MagnaCare is another wrap network. We're also able to do reference-based pricing within these vendors within that architecture. And the PBM is Ventegra with a carve-out specialty with Vivio as far as specialty drugs are concerned. We also have within this all of the Theralta, which is a separate instance of what Lee has built under Health Transformation Alliance, which gives us access, as Lee mentioned, to all of these high-performing point solutions that most in the mid-market can't even get access to because of the volume requirements. The captives that are supporting this initiative is Skyward with their ICS captive, Trinity Health, and on a limited scope BevCap. So those are the three captives that we are participating in their cells until we get this large enough to create our own cell. Okay. Any just general questions? Let me pause for a second. Yes, we have boiled the ocean on this one. You know, we have truly taken a lot of time and consideration in building this strategic bundle. So we're happy to distribute this deck to everyone, but what we're doing, we're limiting also the plan designs. That doesn't limit your creativity. So if you want to do an HRA around this, or you want to do something else with this, you can certainly do that. But this is the basic infrastructure of the plan designs. And that's how we've been able to get, you know, box pricing on our third-party administration, which is significantly below industry, which is, depending on the size of the group, between $20 and $22 all in. And so we've been able to really make it very cost competitive. And so that's why we're able to say that we can get, you know, on an average, you know, 12 to 25% discount over current costs. Okay. Now, this is not a dumping ground for bad risk. That's where Allison comes in. Okay. That essentially, you know, yes, we are going to do, you know, good underwriting, but because of some of these cost containment strategies with Lee's help that we've adopted, that we're able to bring in some risk and be able to effectively manage it to where you can get it into the captive. If you have 3 hemophiliacs and an end-stage renal disease in 100 life group, this is probably not the place. Okay. So having said that, the plan design is that with the incentive, we are trying to make the tier one basically a $0 deductible, except for the qualified high deductible health plans, but we will waive the deductible up to the qualified high deductible health plan amount. For example, on plan design 4, the deductible is $3,000 in using the clinical care navigation. If you go through the clinical care navigation as the individual, that deductible for tier 1 would be down to $1,500, just for example. So these 5 plan designs, high level, you can see the deductible. We actually have a $500 deductible option that we're willing to underwrite. Then we have a $1,500, a $2,500, and then the last 2 plans are qualified high deductible health plans. That incentive, essentially, it could be a $1,500 deductible plan. Okay. We've made reasonable on the out-of-pocket maximum. And for the non-HSA plans, those are embedded. We have copay plans. And as I mentioned to you, we have some very high-level pharma plans with specialty carve-out that we effectively manage through, again, very advanced cost containment strategies. Okay. So this is high level the 5 plan designs. Would love to get feedback. So I'm going to pause for a minute and then we're going to go into the process and I'll turn some time over to Allison.
Heidi, I'm on the call now.
Yeah.
This is pretty exciting.
I think so. I mean, this is, to me, this is really the next generation of health plan designs.
Well, and kudos to you and Lee for all the work in putting this together. I mean, this is the future of healthcare, but there's a lot of details that go into making it happen. And you guys have put the work into that. So just really impressed.
Well, Daryl, thank you. And we've done a couple of trial balloons out there in the industry. And many have said, gosh, this is great, because I didn't have, I'm a mid-market broker and I'm trying to do what's right for my clients, but I don't have the volume to be able to get the discounts. I don't have the volume to be able to get these point solutions. So we were truly trying to solve for the pains of the mid-market consultant and advisor, and do it in such a way that we bring kind of this very simplified but very complex architecture that we've spent a lot of time thinking through. So thank you, Daryl, for the acknowledgement.
Can I just ask, because I did jump on a little bit late, conceptually, the idea is that if I use, this is subscription-based advanced primary care, all of that, there's no copay or deductible for that.
Right. Yep.
If I use the navigation to go where I'm directed to good quality providers, is it feasible that, again, I have no copay or deductible?
It's no copay because they are not giving medical advice.
Okay.
Okay.
So the idea of being able to offer to employees a highly employee satisfaction plan at a reasonable price is in reach.
Is in reach.
Which is really the number one goal here.
Right. And at a time where economic conditions are difficult for the mid-market employer and fully insured is not coming to the call, that under this self-funded chassis, again, with some of the restrictions of the states in their area, in their respective areas, but we're able to fulfill basically this in all of the United States.
Cool.
Okay.
So do others have questions?
I have a question. I'm just trying to wrap my head around the waiving of the deductible on the HSA plans for the tier 1 providers.
Okay, Louis, remember on a qualified high deductible health plan, to be able to have an HSA, reimbursement account, you have to have a minimum of a $1,500 deductible.
Right.
Okay. That's what we waived down to.
Okay,
So
you're waving down to the
we
the
waved
lowest
down to that
possible HSA
1,500.
qualified plan. Okay, I
Right.
missed that. I missed that part.
Yeah.
Okay, that makes perfect sense.
And
then.
so whether it's on plan design 4 or plan design 5, if they go through the tier 1, and then are referred into in-network or whatever the case may be, that's fine. Okay. But then that's where the incentive is you'll have your deductible waived down to that $1,500 level. Okay.
So if you stay within tier 1, you essentially have whatever it is for 2024, whatever,
Right.
a $1,500 deductible, then you're covered.
Yep.
Does it kick into the co-insurance at that point or?
Yep. It does.
Okay.
It
Okay.
does. And so part of this then, Louis, within the plan design itself, and this is where SNS administers the incentive plus the claim. And in doing both, we also have that embedded in aggregation going on as well, even within the claims that are paid under the Theralta clinical bundle.
Okay.
Okay. So it does then meet all the criteria that we need to meet. But, and we all understand, insurance 101, that you're not paying for a $1,500 deductible plan, you're paying for a $3,000 deductible plan in your premium underwriting. Okay. So that's the exciting part, is that we've truly tried to pull all of the clinical levers and the underwriting levers and the administrative levers to bring cost efficiencies.
And the stop loss carrier is happy to waive that extra deductible because they understand that if you stay within that tier one
Yep.
Category,
Yep.
you're going to have a chance of significantly lower the claim spend for those members. Who have
Absolutely.
less
Absolutely.
unnecessary care and medications. Got
Yep.
it. Okay. Thank you.
And to the member level, they feel that they're in a concierge level environment because now they have an advocate within that clinical care navigator that they can call and say, okay, I need to go here. Can you help me? Just guide me to what some of my options are. Okay.
Yep.
So
Going
not
back to
that-
Lou's
Yeah.
Lou's question, if you don't use an HSA and you just use an HRA or EBHRA, then you don't even have to require them to pay anything, correct?
No.
If they stay within the right guidelines.
That is correct.
Right.
Okay. So this is again, but to be able to get the most administrative cost efficiency on the administrative cost, we put it in kind of the incentive side. So we're not having to customize every single plan design. You still have determination of eligibility. Okay. And so there is still some flexibility on those pieces, but the plan designs are pretty well fixed other than the incentives and, or if you, to your point, Daryl, if you wrap it with an HRA or something else like that. Okay. So great questions. All right. So let's
Can I
move
ask
on.
about the
Uh-huh.
navigation? Maybe,
Yeah.
maybe I missed this, but is there one company doing all the navigation, or is it a
Yeah,
multitude of
Rightway
companies
is
that
doing
can
the
do the
clinical
navigation?
care navigation nationally.
What's it called?
Rightway Healthcare.
Okay, thank you.
Okay. So let me kind of pause for a moment. And what I'm going to do is let me turn some time over to Allison, but collaboratively what we did, because what's difficult when you start collaborating is the integration and then things get clunky, right? And so what we did is through a digital backbone, we set up the RFP process that essentially you just go out if you're interested and you link in, and Allison will kind of walk you through that here. So Allison, let me turn the time over to you here real quick, and I'll move on to let me get over to the digital backbone here. Give me a second and we'll go ahead and get that over.
Okay, thanks, Heidi. All right, so as Heidi said, this is what the RFP process would look like. So you would click on next, which would bring you to a page that will give you some options as to what you're looking for. A level funded, a standalone, captive, all of the above. And so you would click on that. And then we get into all of the wonderful things that we need to quote for stop loss. And the group, the name of the group, the address, all of the particulars, SIC code, renewal rate, renewal date, excuse me, current carrier, and then we need to upload the census file. Now, if it's a group without any experience, the carrier does use AI with Gradient, and so they need to capture all of this information, including the dependent information as well. So it's really spelled out here as to what's needed in order for it to be uploaded. You can keep kind of scrolling through that, Heidi.
Yeah. Allison, do you want to just explain for anybody who has never used Gradient AI, not to be patronizing to anybody, but just for the, if somebody is not familiar with them, what they do?
Gradient AI is, there have been multiple AI products out on the marketplace, but where the carriers have really felt the most comfortable with the data has been with Gradient. And they collect millions of pieces of data from all sources that they put into their AI system. And then they can tell whether or not, like Heidi had referred earlier to a group that had 3 hemophiliacs and ESRD and so forth. So they can really see if the group is worth quoting for something for the risk that they're looking at. In the Oh, fully insured space. They've used the one, I can't think of the name of it. Heidi, what's the name of the one that does the PBM piece, the prescription
Yeah.
It's like GRX or
Yeah,
something.
well, it is GRX.
Okay, see, I was close. All right, so GRX. And anyway, this is more information, medical as well as prescription. So they've got a really good, they have really good data that will say this is a great case. And we've had cases turned down that we've sent into Gradient. The beauty of it is that if with the stop loss carrier that we're working with, Skyward, if it does pass Gradient, then it moves forward and we don't need to have individual health questionnaires, which has always been a stumbling block in trying to move a piece to stop loss self-funded. So there's an opportunity to upload your census file, and then we need current coverage information, the effective date, what type of contract, specific deductible, all the different things that you're looking for, and information about the group. And obviously, if you have any special eligibility, if you cover board members or you cover retirees, things like that, it's imperative that we know that information. And then also, if you have a self-funded case or a level funded case that you would love for us to look at, that would be great. But of course, we need claims experience, paid claims experience, large claim information. And so this really just explains all the different pieces that we have to gather in order for us to be able to get a quote for you. And then once you put it into the file, and we would review it and say, hey, we're missing these pieces, or everything looks good, and we'll send it off to market, and we can get you a quote back. They're pretty much working on about a turnaround from a group that has everything that we need. Takes about 10 business days from the point we get it in order for us to get a quote, especially for January 1 business. And we're hoping to have this all up and running for September 1st.
So really quickly, before we kind of move off of this, Allison, one of the things that we've done as well with the product is that we have netted everything of commissions. And so if you want to load commissions in, even though I know part of the aspirational healthcare, mantra and guidelines are that we're fee-based, full disclosure, et cetera, that if you want us to add a fee in there for you, again, in full disclosure, we can do that. But part of this is, again, truly trying to be in a transparent, cost-effective environment, and however you want us to do that, you'll just need to give us instructions on how to do that.
Thank you. Well, I just applaud you for that.
Well, Heidi, so that's great news to hear. But does that reconcile easily with the new CAA?
Yes, all of it.
I mean, it's what brokers need to do anyway.
Yeah.
Right.
It does, but there's still a lot of overrides and those types of things that are all, still being, played with a little bit. And so we're very much in alignment with the strategy, et cetera, and want to make sure that everybody is just aligned with that. That's it.
Yeah.
Okay. So at least for our product offering, that's what we're going to do within, and let me just real quickly go back real quick for one last thing that, Allison, do you want to talk to all of the other documents that are also, let me pull it back up again. That any of the documents on the RFP, what they'll be able to access as well.
So you've got a number of direct primary care practices across the country that are jumping in. Is it open doors so that anyone that can meet a certain set of qualifications can also participate? And so what does that open door look like? In other words, is there a set amount that you're kind of saying, take this much per individual or this much per family, or give me some idea there? And I know I missed the first 10 minutes.
Yeah, no worries. Lee, do you want to kind of address that high level?
So Daryl, unpack that for me a little bit in terms of the sort of mark to market there, patient by patient.
Well, direct primary care practices everyone's different in what they charge. So I understand that originally your plan was to say, this is what we're going to be willing to pay. You decide whether you can provide these services within that. Is that what you've developed here? And so if you want to jump in as a direct primary care, that's kind of what you have to meet. Here's the services you have to offer, and here's how much you have to be willing to take.
Yeah, that was the first design. So we said, I think we put the fee at like $60 and said, this program pays 60, you need to be able to offer these things. And when we started looking at that at a national level, we realized we had the right, if 60 was a perfect average, that we realized that for half of the providers, we were paying them too little, and the other half, we were mathematically paying them too much. And we sort of had to retread. They came to us and said, look, Lee, if you're only paying me 60, you can't come see none of your people who live in San Francisco or New York can see a doctor.
Yeah.
Because we're below break even at that level. So you're leaving them all out. Oh, and so that means you're left with, Wichita and Des Moines. And guess what? You're paying too much for all of those places because we could do it for 45, not 60. So, joke's on you. So that was where we said, okay, now we gotta rethink that. So now we say to them, please come, please participate. You choose your price. However, our employers will each individually, they're going to be able to set caps on how much they're willing to pay. And so if you get a little too exuberant and priced too high, you're going to get left out. And also it will become competitive over time. At first, we just need to get a good network. But over time, if we've got 22 different clinics across 8 different providers in Houston, and there's pretty good coverage and choice, the employers are going to get more sensitive about what they're willing to pay. They're going to look at the average, and the higher priced providers are going to get left out. So we invite everybody to be. If your outcomes start to slip, you are at risk of being left out and or removed from the program, or have your reimbursement haircut. So anyway,
is it possible within this model? Is it possible within this model for an employer to say, I'm willing to pay up to 60, but if you want one that costs more, it can be employee deduction?
Yeah, that's phase 2, because operationally it's really tricky, but yes. So there's 2 operational items that are pended but kind of in development. The first is sort of the cap extension, where you say, I'm willing to pay 60 a month, and the employee can pay the difference themselves out of their checkbook or their HSA or whatever. Getting it on a deduction out of their paycheck would be phenomenal. For a large organization, that's a 2.5-year process to even make a small adjustment there. So we're not looking to do that soon. But the other piece is some employers, we've been able to fend them off so far, but at some point we're going to have a really big, important employers going to insist that there's a copay applied. Again, we're trying to keep that away, because even a small copay will drive a lower income person, and even a high income person who's watching the pennies, they're just not going to go to the doctor if it's going to cost them anything. So far we've been able to hold them at bay, but we suspect at some point there might be somebody who forces us to do a copay, and we'll have to figure out how to add that.
So Daryl,
well, you've done awesome. This is amazing.
Yeah. And let me answer it maybe a little bit added way as well. So as I mentioned, and Lee just mentioned as well, we have data analytics embedded in this. So data analytics becomes at the top, but also a safety net at the bottom for performance. And so we are going to be monitoring these point solutions based on their performance as well. And so we'll be evaluating them. And Daryl, as things, let's say somebody is not performing anymore and a new innovative strategy comes in, that we'll be able to replace it. Okay. So we'll be doing ongoing evaluations, but right now, probably it will be a semi-annual, an annual review, whether we make adjustments. We won't be doing it on quarterly right now. Okay.
What I love about this, I just full disclosure, the companies I work with are large enough that no one buys stop loss. So I know nothing about stop loss. I rely completely on Heidi for that sort of thing. And of course, Allison as well. But something that's really interesting here is that my large employers, we're always looking to validate the different programs that we're spending millions of dollars on. But once we validate them, it's sort of, do we keep it or dump it? Do we have time to replace it? Those are sort of the decisions that come in. What's fascinating about stop loss that, that I've been learning is that if we validate the value of a program for a large employer, they just kind of feel good about it or they get rid of it. But for a smaller employer, if we've got good validation around the performance of a particular strategy or solution, it applies to another product that they're purchasing in the form of the stop loss and obtaining a decrement as a result of the performance of that. So there's a huge incentive to validating the performance that exists for smaller employers, because it really does impact immediately sort of the value, or not immediately, but certainly the following year, the value of their stop loss premiums. Whereas a large employer doesn't get, they don't have that added incentive to really know if their programs are working. And it's pretty exciting. A question just came through on the chat. What's the minimum employer size? Heidi, I think that's
yeah. The minimum right now within the stop loss umbrella is, depending on the state, 25 plus. Okay, but I would say 51 is normally based on some state restrictions other than New York, which requires 100 plus. But at the time that you submit, so what I would suggest is, and we'll be giving Daryl kind of this full distribution packet, but is that if you have, a renewal, try it, just go out and test us. And we'll be able to demonstrate to you the cost effectiveness of what we're doing. Okay, but we'll let you know if the state that you're asking for is somebody's situs in New York and you didn't know that was 100 plus requirement, we would let you know. Okay. Any other questions on that? I know we have a few more, and thanks, Lee, for monitoring the chat.
I had one question. I just noticed on the RFP process, when you looked at dependents, it didn't list domestic partners. Is that not eligible, or would they go under the category of other?
It'd go in other.
Okay.
It'd go in other. So within the portal, you'll also be able to access, you'll have different navigation buttons over here, and these will just expand, but you'll have the plan design, you'll have the clinical bundle overview, which is all of the Theralta, which, you'll be able to see all of the summary of the benefits. You'll have SBCs, etc. in there. So all of this information will be in that repository. And you'll be able to see that. Once, if it's approved, then Allison will turn it over to SNS, make introductions, and you'll just start the implementation process. Okay. And all the servicing is done out of SNS as an administrator. So Lee, we're at, a few minutes before time. Is there anything else that we can send you? We're going to get you the packet. We're going to get you the deck. But how, just, give me, a little bit of feedback. Is my baby ugly? Lee can't ask that because all of his kids are cute. So
I think it's beautiful, but I'd love to hear from others.
Heidi, I just asked a question.
Sure.
In the chat that if you could respond to.
Yes, we do have predictive analytics.
So I know you have predictive analytics. I'm saying if we have predictive analytics companies that want to work with us, that want to bring us their clients, can we use their services in our white label offering?
We're not going to be able to put them in as a replacement of what we already have. This is kind of integrated, but you can use it separate. Sure.
So, okay. So it would just
and
be
the data will feed over. You can get all your data wherever it needs to go.
Oh, okay. Okay.
Okay.
I think that's what you're asking, right? Is the data all
saying,
locked down?
Yeah, we're just not going to be able to fully integrate it into the
that's
bundle.
okay.
Yeah.
Hey, I got you. So you essentially arranged for real easy, supportive service, because everybody's trying to figure all this stuff out. So you're making it easy for other people to work with you. I got you.
Yeah.
When I
And-
talk
and-
about the toys, Heidi, I want to talk about the toys that are in it.
Okay.
Okay.
Talk about the toys.
Okay, so let me tell you what we've got in this thing. So the first is a toy that's being used by, like, this is brand new. It's being used by a couple of the Fortune 50 and a handful of large carriers. And it is a data relay system that enables you to set up and create a data feed between your TPA and any vendor of your choice. Maybe you can't decide, you're like a kid in a candy store and you buy 3 data warehouses, Springbuck, Innovu, and I think we already have Artemis. Sure, you get all of them. And normally it's a 6 to 9 month to get that stuff set up. Under this program, we can set up a new feed, and you can actually just send a tech support a request for a data feed. And I think within a week we'll have a feed going to any vendor that you need for it to go to.
That's cool.
It's
pretty cool.
There
It's
will
gonna
be a
change
minor
everything.
cost for the feed, but it's not huge.
Oh, and the cost of the feed right now, we're trying to get this locked in for everybody, like as many years as we can. It's $10 per month for your feed. And just to benchmark that, UHC is charging me $4,700.
Yeah.
Whoa.
Cigna has cost me it's an annual of $6,000. I mean, we're talking almost a double order of magnitude improvement in both the speed and the dollar cost of setting up data feeds to any array of vendors, not just the vendors that we have, but say you have a preferred telemedicine that you like, 98.6 or Teladoc or whatever, your customer and you're going to bring that to the new arrangement. You can sign that up and we'll be able to get the data flowing on a direct solicitation, direct request. The second one is Laguna. I'm so excited about this. Okay. Again, only a couple of massive companies are using this and one insurance carrier is using it on Medicare Advantage. What they do is when you go to the hospital, imagine like when you or a loved one has been to a hospital recently, you come out of the anesthesia, you can't think, you then end up going home. About 1 in 8 people, depending on the hospital, 1 in 8 to 1 in 12 people who go home after a surgery ends up having a complication problem and then a readmission where you have to go back to the hospital. And it's a huge problem. And you think, well, why does that happen? And it's like, well, think about how they discharge you, right? They put you on that wheelchair and they boot you off the curb. Hopefully you have a loved one to come pick you up because otherwise you're in real trouble. You get home to your house, you're in a delirium, you're in pain, and they're like, oh, here's a script, go and get your prescription drugs. Well, what happens if you live alone or have a not great roommate or something like that, right? Like not everyone has like a stay-at-home spouse who cares about them enough to go and get this taken care of or whatever it might be. And so you have people, what if you're a single parent or something like that? You have people who are going home, they can't get to CVS or Walgreens to pick up the drugs, or maybe they forget how to take them because the doctor gave you the instructions while you were just coming out of anesthesia. You don't remember any of your discharge, right? And so you get home and a non-zero number of people, a reasonable percentage, they never get the drugs they were supposed to get. They forget that they're not supposed to move or that they are supposed to eat or not supposed to eat or whatever it is, because they don't remember any of the discharge instructions. And so it's like 30-ish% of people are actually following doctor's orders when they get home. The only miracle is that we don't have more than 10% of people ending up back in the hospital. And but those that do occur, they can be life-threatening and hugely problematic. And usually when they readmit, they're in the hospital much longer than they were the first time. It ends up being a lot of the most profitable for the hospital and most expensive events that can occur to the customer. So what does Laguna do? Laguna calls you as soon as you get home and says, hey, did you get the medicine you're supposed to get? No, I didn't. They're like, okay, we're going to get it sent to you. Second question, do you remember anything you're supposed to do with the discharge? Okay, can you tell it back to me? Let's make sure that you understand it. Turns out you don't understand. Okay, well, we're gonna go over it with you. Oh, and I'm going to call you tomorrow to see if you actually did that. And they call you every day. Oh, and they say, what color is the wound? It's kind of turning green. Okay, it's not supposed to do that. I'm getting you in an ambulance right now. We're getting you back to the hospital immediately because that's not the color it's supposed to be. They just check and they ask the most basic normal things. Are you following the instructions? Are you taking the medication you were told to take? And what color is the wound? Is it doing okay? Now, when they first spoke to me, I said, okay, that's cool. They're like, we have a PMPM. I'm like, I'm not going to pay you a PMPM. I'll pay you per patient though. They're like, okay. Second is, I said, do you have results? They said, yeah, we did way better with all the people who engaged. I'm like, that's not valid results. That's volunteer sampling bias. It's not publishable. You need to get me results that are controlled for volunteer sampling bias. Like, how do we do that? I said, well, you need to sort of get every other, and you need to include everybody you try to reach, not just the people you did, and look at their results. And you should do it from somebody who's already doing a good job. And the leaders of this company, they're like, okay, they're the only people who've ever taken my advice. They then called over to Cleveland Clinic, and they said, okay, Cleveland Clinic, you have the best readmission rates in the United States. They're ranked #1 out of 5,200 hospitals. They said, we want to do this study. We'll do this for free. Give us every other of your patients for like a month. And the one, just 1, 2, 1, 2, like on the playground, we're going to call all the ones and we're going to do this for them. Did you get your medicine? Do you remember and understand what you need to do on your discharge? What color is the wound? And we're going to check in with you every day. And then the other people will just do your regular stuff. And they're like, well, we're already the best ever. Our nurses check in with people, et cetera. They're like, yeah, but we want to see if we have something that's real. And so they did it. And already on the #1 lowest readmission and complication rate in the United States, potentially in the world, they were able to reduce, they reduced slightly the number of readmissions and complications. But here's the really interesting thing. The length of stay for the readmissions that occurred was like 70% less. Because the second that wound started looking infected, they got the person immediately back to the hospital and they were in and out in a day. Versus on the control group, the very few people who had to get readmitted, the wound turned green. And then like 4 days later, when their whole body was starting to go into shudders and they were starting to sweat profusely, that's when they went back to the hospital. By then it's a much bigger problem. And it's like $250,000 more expense. So massive savings. We think this will have like 20-to-1 ROI. Unfortunately, if you're not a huge employer in the know who's been like connected into the VCs that are funding this stuff and the early results on that publication, you don't even know this exists. Half my members don't yet know that this capability even exists. I'm just now starting to get the word out to the more progressive ones. It's already baked into this program so that your 50 Live group can have access to it. So cool. Okay, let's do another one.
That is pretty cool.
Okay, so I just want to be
Anyway, I
respectful.
know we're over.
Sorry,
Everybody's
Lee.
dropping off. That's okay.
I know we're over. So what we'll do is we'll send the deck, which has all of these in them, and then we can certainly, Daryl, set up a time with the group to answer questions again, or they can just reach out to us. So
Yeah,
we've got
I think this is worth another meeting, and whether we do it at the next one or the next one, this is big. This is like Nuka big. The word in Alaska Native language for Nuka is something really big and beautiful. This is Nuka big. So I commend all of you for all the work on it.
Well, I appreciate that, Daryl, and thank you, everybody. I enjoy participating, with this group when I can join, but know that this is just one of kind of the things on my plate, but certainly committed to it and wanting to make sure that we're successful in the market. Okay.
Yeah, this is amazing.
All righty.
Awesome.
Anything
Thanks
else
for those.
before we go?
Today. Take care.
All right.
Thank you, guys.
Bye-bye.
Appreciate you. Thank you.